Good evening and welcome to UOA On Demand. I'm Dr. Christopher Doumas, hand and upper extremity specialist at University Orthopaedic Associates. Joining me today are my fellow hand and upper extremity specialists, Dr. Ryan Coyle and Dr. Hesham Abdelfattah. And today we're going to be talking about basilar thumb joint arthritis. For those of you who don't understand or know that, that's going to be basically hand arthritis at the base of the thumb. It's a very common condition that occurs in a vast majority of the population over time. So we'll start off with Dr. Coyle. Can you explain to us exactly what basilar thumb arthritis is?
Thanks, Dr. Doumas. Basilar thumb arthritis is pretty common. It's the second most commonly affected arthritic joint in the hand and probably the most painful one. It's the joint between the thumb and the wrist, essentially, and it's a very mobile joint. And that's because the thumb has to get out in space and to grasp objects and then to pinch them. So this joint is very mobile. It sees a lot of force. It can see up to 12 times the pinch force at the base of the thumb compared to what you exert at the tip. So it's a joint that sees a lot of force and is commonly affected by wear and tear. So it's a common problem. A lot of people have it, and it's difficult when it's a younger patient who develops it, because people that are doing more with their hands, that are gripping, lifting, twisting, and have degenerative change at the base of the thumb, they can develop pain. The cartilage wears away, and over time the joint can become, essentially the joint can narrow, the joint can get inflamed, and that inflammation in the joint is very painful for people that are especially doing that a lot of physical labor, twisting. But again, this is a problem that a lot of people experience, and not everybody has pain, but the ones that do, this can be very debilitating.
Thank you. Dr. Abdelfattah, how do you diagnose this problem?
So the thumb basilar arthritis, or thumb CMC joint arthritis, as it's commonly called, is mostly a clinical diagnosis. So some of the testing that we do after we examine a patient in the office who complains of pain in the base of their thumb here, pain with specific motions and activities such as grasping, pinching, opening jars, opening doorknobs. Sometimes if it's bad enough, even pain at rest. So mostly it's based on their symptoms, in addition to some testing, clinical testing, most specifically, plain X-rays. We don't need any additional advanced imaging like an MRI or CT scan usually. But a plain X-ray can basically give us all the information that we need in regards to, determining the severity of the amount of arthritis. So anywhere between some mild joint narrowing all the way to complete obliteration of that joint and big bone spurs, or what we call osteophytes, and any instability of the joint also can be kind of seen on these plain X-rays. So it's a combination of how the patient presents in regards to their symptoms, and what we see on examination in the office, and some plain X-rays.
Great, thank you. So, early line treatments, non-operative treatments, I typically use anti-inflammatories, standard stuff, Tylenol as needed, but the anti-inflammatories, as long as you can take them, are usually a little bit helpful. There's soft braces they sell in most pharmacies. There's more rigid braces that hand therapists can make, and you can also buy online that help with this, that I utilize quite a bit. There's other things like hot wax baths, paraffin baths, I find help hand arthritis a significant amount. So I usually try hot soaks, and then if that continues to work, you can try some paraffin baths to give some short-term relief. There's steroid injections, things like that. Anything else that you guys use in your armamentarium?
I think that I've had a decent number of patients be successful or have some success with topical medication. So things like, not to use any brand names here, but Voltaren gel, which is an over-the-counter medication now. And so I've had a decent amount of patients tell me that that's helpful, or even some of the other kind of topical salves, if you will, that they apply to the painful arthritic joint that can be helpful. So that's something that I often recommend to patients.
CBD cream also there's some literature about that in the last couple of years.
Right.
Some people try it, some people don't. But like Dr. Abdelfattah said, the topicals can be helpful in the hand, because it would make sense that joints that are closer to the skin might see more effect. I don't know that we have any data to back that up, but people do sometimes see some significant benefit from topicals.
Great. So one of the other things I also try to recommend to my patients is, if it's their dominant hand, using a thicker pen. It just helps to take the strain off. So instead of doing tight pinching, you've got a wider grip on a pen. So a thicker pen can be helpful if it's the dominant hand. thicker golf clubs, tennis rackets, things like that. I find also it helps to take some of the stress off of the grip. So I think those things are also very helpful.
There are a lot of adaptive equipment that they can buy, even online on Amazon, that help with opening jars, wider grip pens, like you said. And there's a lot of things that they can work with a certified hand therapist on, trying to adapt their workspace or some things at home that are affecting their hands more, causing more discomfort. And so, yeah, so a lot of the different pieces of equipment can be used to really kind of modify their activities and help a lot with their symptoms.
Agreed. And I think probably 99.9% of the patients I see with this condition, opening jars is one of the chief complaints of people with pain opening jars and having difficulty doing that. So there are a lot of devices out on the market for that type of situation. So, when all else fails, unfortunately, and injections, stop working or don't last that well or just don't, take effect, surgical treatment does come into play with this, and it depends on the different stages and things like that. I find there's also a difference in whether it's a traumatic injury at that joint and can lead to some instability. I always explain this. If you look at the x-rays, I kind of explain it as an arthritis of instability because you see some subluxation or where the joint is sort of moving a little off kilter. I always explain it's just not lined up properly. So in early stages or for early traumatic stages, there are some simple surgeries like arthroscopy of the joint with capsularaphy, which is basically almost like a thermal shrinkage where you're tightening up the ligaments. There's different ligament reconstruction procedures, and then there's more salvage procedures. If you want to go through some of that, Dr. Coyle, as far as what your first line of treatments are for these from a surgical standpoint.
Sure. So, like Dr. Doumas mentioned, there's a lot of different. This problem progresses in a pretty, predictable fashion, and over time, the joint, tends to narrow. And in some patients, especially those who have loose joints, the thumb metacarpal, which is the bone at the base of the thumb, will slide out to the side and can wear eccentrically on the joint. So essentially, the name of the game with treating this problem is to remove the inciting factor for the problem. So in patients that are young patients with a very loose joint but with intact cartilage, which you can see it on an MRI, but in general with normal X-rays, instability and pain there are procedures that can sort of weave up the ligament stability, and there is these procedures are reported on the literature. It's not a common problem because most of the patients that come in with basal thumb joint pain are older. But once the joint is degenerative, then you sort of have to remove that bone on bone or that abnormal cartilage wear surface. So to some level, you're either fusing the joint or removing in the vast majority of the cases, that's not the treatment of choice, but you're either removing part or all of the trapezium, which is the bone that the thumb essentially sits on. And then once that's done, there's any number of different reconstructive procedures you can do from simply nothing, from leaving the space open to taking a tendon graft and passing it through the bone, or using either a suture anchor or even a implant arthroplasty that goes into the base of the thumb and sits on the essentially takes the place of the trapezium. But essentially, you're trying to remove the diseased bone-on-bone articulation, which is causing the problem in the joint, and then making sure that the joint remains stable enough so the patient can use their thumb and pinch and grip, do the things they want to do.
Dr. Coyle, what is your surgical, go-to procedure for, basilar thumb arthritis? I know there's a lot of different ones that can be done, different techniques. If you could just explain shortly, what you do as a preference.
Sure. So this is obviously controversial, and in orthopedics, if there's a lot of different ways to address a problem, then they tend to all work. If there was one way that worked better than others, then everybody would tend to do it. But what I tend to do, my preferred procedure is what's called the internal brace procedure. We remove the trapezium, and then you use a suture anchor in the adjacent metacarpal bone, and in the suture anchor in the base of the thumb metacarpal with a suture that's in between. It's strong enough to resist the forces early on in the rehab process, such that you give the thumb capsule the CMC capsule time to scar down and hopefully resist translation. Because the concept is that as long as the thumb metacarpal doesn't rub on the scaphoid, which is the next bone down in the wrist, the pain is improved. That's one way to address it. That's what I tend to do. But obviously, there's many different procedures that are out there.
Dr. Abdelfattah, what do you do as a procedure of choice for this, and any particular reason why?
So I agree with Dr. Coyle on this. I mean, in training, I probably learned 8 or 9 different ways to do this, and I think all of them worked, about the same, as long as the common denominator is addressed, which is the arthritic surface. So you're excising that trapezium bone. I use some. For me, it depends on patient age and activity. So, for older, more sedentary patients, I use what's called basically a suture suspension plasty, which is basically a suture that brings two of the tendons together like a hammock that holds that metacarpal from subsiding. And that's been shown to be pretty effective and pretty cost effective actually for patients, and they have some pretty good mid to somewhat long term results. For patients who are a little bit on the younger side, meaning if they are like early 60s or earlier than or younger than that, and they tend to be a little bit more active, I will do similar to Dr. Coyle, an internal brace or some sort of what we call tightrope, which is also, not to use another brand name, but some sort of device similar to that would provide a stout enough, reconstruction or ligament substitute, so to speak, in order to get them moving soon enough. My goal is to get them starting rehab within a couple weeks. So I don't like to, I don't like to hold people in a cast for 4 to 6 weeks before starting. I think with the newer surgical technology that we have, we're able to get people back to life much quicker, and we're able to get them rehabbed much quicker. And so I think these devices like the internal brace and the suture anchors and the different types of devices that we have now allow us to be able to get people moving much quicker.
Great. And what other associated conditions do you commonly see with this? Are there any other things we need to look out for? Patients, if they're going, seeing other physicians, seeing one of us, questions they should have in the back of their mind, things that they could be looking out for, as far as what else they need to be worried about in the area or adjacent joints. Dr. Coyle.
So, there's a couple different other joints in the area that can either be associated with or sort of masquerade as CMC arthritis. So the adjacent joint in the hand called the STT joint was the joint between the scaphoid and the trapezoid, and also the base of the trapezium. That's addressed partially by removing the trapezium, but if there's arthritic change between the scaphoid and the trapezoid, that also needs to be addressed, and typically that can be done through the same incision by removing a little bit of that diseased trapezoid bone. That's one thing you don't want to miss. Another problem you don't want to leave alone is either a hyperlax or an arthritic MP joint, because if the joint is, and especially in a patient with a lot of ligamentous laxity, over time in a really diseased CMC joint where the thumb subluxes, you can get compensatory extension of that joint. And if you just do a trapeziectomy, removing the trapezium, or an address instability there, the patient will still have difficulty pinching and pain there because of laxity. And I do see a fair number of patients with carpal tunnel syndrome at the same time, and that can also be addressed. And I think it's appropriate. You don't want to do too much at once, but at the same time, carpal tunnel surgery and basal joint surgery, I think very appropriate to do for the right patient who's having problems.
Okay. Thank you. Anything else you can add, Dr. Abdelfattah?
No, I agree. I mean, I think the literature shows that up to, some places say up to even almost half of patients who have advanced thumb CMC arthritis have some symptoms of carpal tunnel syndrome. So they're associated conditions. They are not, the same thing. It's not at least we don't think so. It's not the arthritis that causes the carpal tunnel syndrome, but the people who tend to get one tend to get the other, or so we think. And so I agree. A fair number of them present that way, and we can address both of these at the same time. It doesn't affect or prolong the rehab. It actually helps their symptoms improve more rapidly. And so, and I echo what Dr. Coyle said about the adjacent joints. Some patients that I've seen having had surgery potentially elsewhere and not having complete relief or still having ongoing pain, sometimes some of these adjacent joints have not necessarily been addressed, or some of this, potentially can be missed. So it's something that we need to make sure we pay attention to, the adjacent joint arthritis, both at the MP joint here, or the laxity that can occur as a compensatory issue, or the the STT arthritis, or the trapezoid bone being arthritic in the same setting. And so those have to be we have to make sure we inspect those, and really be diligent about addressing those issues at the same time, because if we don't, relief, maybe that the patient's relief isn't necessarily what it could be after surgery.
Right. And, I see a pretty significant amount of older patients as well. I mean, up in their upper 80s and 90s even, that have really severe deformities and severe arthritis. I'm sure you've seen some as well, where they literally have no pain, but they've got a horribly deformed hand, and you look at and wonder how they can function. So some people just, I guess, whether it's lucky or unlucky, don't get good position of their hand, but they could have horribly narrow joints and very subluxated or dislocated joints with very big deformities at the base of their thumb, and compensatory extension at the thumb MP joint, and they still can function quite well and never need a procedure done. And it's because I think the joint gets so stiff, it almost auto-fuses in those cases. But it's pretty impressive, the deformity that some people can withstand with this. And then some who don't have significant deformity or even severe arthritis, and they've got severe pain that occurs in the joint. So I think some of this is still not always fully understood. I think one of the final points I want to get across is, there's a lot of people out there doing different types of injections and things like that. I personally do steroid injections for these occasionally, to try and help get people over the steroid, the arthritic flares that tend to come with these. But there's, different things like PRP, hyaluronic acid that people inject into other knee joints, stem cells, things of that nature that are out there and on the market that people are doing. Can you help guide some of the patients as far as what is out there in the literature, any experience you've had with those types of injections?
I mean, I as far as I'm aware, I don't know of any data to support anything other than cortisone injections, or steroid type injections, really for relief. Everything else that has been studied, that I'm aware of, including hyaluronic acid and I think PRP, have been no different than placebo. So I think the tried and true, for as far as injection goes, is some sort of steroid injection that helps reduce some of the inflammation that occurs with some of these flares, that happen in people with arthritis. So that's generally what I stick to if I'm going to. And I'm pretty liberal with injecting people who have pain, and they've not had any issues until 2 or 3 months ago. And I don't surgeries. I always tell people when they present to my office with an arthritic complaint like this, is surgery for this is entirely based on their symptoms, and their what their goals are, and what it is that they can and can't do, and how long the symptoms have been going on, and whether we've tried anything else before we jump to surgery. I mean, arthritis in the hand, much like arthritis in the knee and the hip and other parts of the body, we don't have a cure for arthritis. We're treating the symptoms and trying to keep you as functional as possible for as long as possible. So I think I think the injections tend to work quite well for people, especially earlier in the disease process. When you have really advanced disease, doesn't always work as well. And so I think the steroid injections are kind of the tried and true in that regard.
Yeah, I would agree. Dr. Coyle, anything else to add regarding thumb arthritis?
Yeah, I would definitely echo exactly what you said about the older patients with horrible X-rays and minimal symptoms. At the end of the day, I think the vast majority of people that I operate on this for this problem, and I probably see 10 patients at least in the office for every one that ends up getting surgery, because the vast majority of patients that need surgery for this are the ones that are younger, laborers, or at a point in life where they're not ready to modify their activities to give up things they want to do. As we get older, I think the name of the game is education, and understanding the problem, and figuring out if there are ways that we can deal with this problem conservatively. Because as Dr. Abdelfattah said, the game is to not to do surgery, not to fix the problem, but figure out a way to live with it, because we have not found a way to reverse arthritis, whether it be stem cells, PRP, or any of the different other medications out there that people are injecting. There really aren't too many. There isn't a gold standard out there in terms of an injection. Like, one thing that we didn't really go over, which is newer, is deinnervation of the CMC joint, which is a procedure that can be done whereby the nerves that supply sensation to the CMC joint are sort of divided. That's another option out there. I don't know that there's any superiority to that over just a trapeziectomy or any of the other varied procedures we have for this. So that's another option out there in the literature.
Right. I think another area of future research that a lot of people are doing right now as well is arthroplasty, which is talking about implant arthroplasty. Yeah, everybody knows about hip replacements, knee replacements, shoulder replacements, things like that. We have other replacements we do in joints in the hand, but there's a lot of different implant types that have come out for this over the years, and a lot of them have had some failures, some more significant than others. And there's still some designs out there. There's still some studies out there that are doing this. I personally don't do them, don't recommend them to my patients. I'm assuming that you guys probably are the same. I could be wrong, but I figured if you can comment on that briefly.
Yeah, I'm not an early adopter of any of the implants, just because of historically the previous implants that have been on the market have had some pretty bad failures. So I know there are some newer implants available that are a little different, but we don't have enough data to really support their broad use. I think in the right patient with the right goals and right expectations, it could be reasonable. But I probably will not be jumping onto using those more commonly until I see some of that data.
The patient where you talk about these sorts of implant procedures on is a younger patient with very high physical demands, and like Dr. Abdelfattah said, the smaller a joint, the smaller the implant, the much easier it is for it to break or to dislocate or to wear. And there's any number of small joint implants in the hand that have had questionable track records. So it's very hard to beat the track record of a basal joint arthroplasty. And the gold standard is a tendon transfer, tendon weave, and an anchovy. And that's something I have done for a few patients. And as patients get older, the bone quality may not support an anchor or other hardware as well. The gold standard older procedure, the LRTI, is really tried and true. So it's tough to beat that track record. And for a young patient who really doesn't want to lose any pinch strength, the fusion is always an option, although there's a lot of motion that's taken away when you fuse the CMC joint. So that's one of the advantages of doing a trapeziectomy as part of the procedure, the motion that you preserve.
So I guess that'll wrap it up for us tonight. I want to thank Dr. Ryan Coyle, Dr. Hesham Abdelfattah for joining me, Dr. Christopher Doumas. We're a small part of the team at University Orthopaedic Associates. You can reach us at uoanj.com for any of your orthopedic issues, especially thumb arthritis. Thank you.
Thank you.
Thank you.